An 80-year-old male presents with altered mental status. Emergency Medical Services reports he was in a normal state of health until he felt generalized weakness and started vomiting. The family states he was not acting right and asked for 911 to be called, which he never does. On arrival, his GCS is 7, and he is not protecting his airway. He had equal chest rise and is tachypneic. You ask for the patient to be placed on the cardiac monitor, a full set of vitals, intravenous access, and a blood glucose level. His blood pressure is 66/34. Heart rate is 250. Pulse oximeter shows 82%. The respiratory rate is 26. You see this on the cardiac monitor. Pads were placed on the patient for synchronized cardioversion at 200 joules. Given critical illness, sedation or analgesia was not used. Amiodarone bolus and drip was started. The dose is 150 mg over 10 minutes, followed by 1 mg per minute over 6 hours. The patient returned to a normal sinus rhythm. Now we must consider why this patient had a wide complex tachyarrhythmia. Atop the differential diagnosis is ischemia. Also, consider hyperkalemia and sodium channel blockade overdose. Given this, obtain a CBC, BMP, troponins, BNP, and chest X-ray. Give the patient aspirin. The patient will need an emergent cardiologist and electrophysiologist evaluation. Transfer the patient if your institution does not have a cardiac catheterization or electrophysiology lab, as the patient will need to be assessed for a definitive coronary artery lesion. And placement of an implantable cardiac device. A pearl to take away from this case is GCS less than 8 does not always mean intubate. This patient was altered from poor brain perfusion from unstable ventricular tachycardia. This altered patient needs electricity and not an airway.